Good afternoon, everybody. I'm Ruth Katz, the director of the Health Medicine Society program here at the Aspen Institute, and I'm delighted to welcome all of you here today, and particularly to thank you for coming out given the horrible weather. It's great to have such a good crowd here. Today's program is part of the Alma and Joseph Gildenhorn book series, which is one of, frankly, one of our most popular, but certainly one of our most special programs here at the Institute. I want to take a moment to thank Alma and Joe Gildenhorn for their sponsorship of the series, and of course to tell them how proud the Health Medicine Society program is to be a part of today's event. Now, today's program features Libby Rosenthal, right here, of Kaiser Health News, about her new book, right here, The American Sickness, How Healthcare Became Big Business and How You Can Take It Back. She will be interviewed, or I should say Joanne Kenen of Politico is going to introduce Libby and then moderate our session, and I'll tell a little bit more about Joanne in just a moment. But first, if I could just tell you a little bit about the Health Medicine Society program here at the Institute. We are one of 30 policy programs at the Institute. Our focus is on domestic health issues, many of which Libby is going to touch on, no doubt, today. The Health Medicine Society program is also a co-producer of Spotlight Health, which is the lead-in session of the Aspen Ideas Festival. I'm sure many of you know all about the Ideas Festival, which is held each summer in beautiful Aspen, Colorado. Spotlight Health features about 150 different speakers over 2.5 days of all programming related to health. It includes entrepreneurs, business executives, government officials, academics, and many, many more. And I promise you we have lots of fun stuff that goes on as well. And we'd love to see all of you there. If you'd like to learn more and even sign up for Spotlight Health, just go online, type in Spotlight Health Aspen Ideas Festival, and we'll get you right there. It will, in addition to telling a little bit about the program, it now has a list of the many speakers that we expect to have, one of whom is Joanne, who's actually been at Spotlight Health for a number of summers this year. So we're delighted to have her here today. Let me just tell you a little bit about Joanne, if I can switch pieces of paper here. Joanne is Politico Pro's healthcare editor. She's covered a ton of stuff, but since 1994, when you first arrived in Washington, she's focused on health policy and health politics. Joanne joined Politico in 2011, and her work has appeared in numerous publications, including The Atlantic, Kaiser Health News, The Washingtonian, The Washington Post. The list goes on and on and on. Joanne has also published a couple of books on her own, unrelated to health, The Costa Rica Reader, and a parenting book, The Sleep Ladies, Good Night, Sleep Tight. And with that, I will turn the program over to Joanne. I think you're all mic'd up.
Okay.
Thank you all again for being here.
I always say that the Costa Rica book, which was years ago, was adopted in university courses, and the Sleep Lady put my... Am I not on? Is this on? Can you adjust? Is it okay? All right. So I always tell people that the Costa Rica book was adopted in courses, and the Sleep Lady put my kids through college, or the one who's gone through college. This is Libby Rosenthal, who is currently the editor-in-chief of Kaiser Health News, which is a wonderful nonprofit health news service, health and health policy, run by but independent of the Kaiser Family Foundation, which many of you know. Before that, she was at the New York Times for many years, and she did a really eye-opening series on the cost of care and how shocking it was even to those of us who cover and live in the healthcare world. And she's also a physician and emergency medicine, and she worked over it. She didn't do healthcare. Unlike me, she hasn't been doing healthcare for years. She worked in China, she covered the environment, she covered politics, but for the purpose of this conversation, she's brilliant at healthcare. And she's also she was an ER doc. That's how she started out in grown-up life in New York City. Right. So, I told Libby that I didn't over-prepare because we know each other, we like each other, and we are going to sort of have the same kind of conversation that we would be having if we had lunch. And we actually started it in the other room, but I've got to now revive it here. And I actually wanted to start with one very brief story that I didn't tell Libby about, and it is brief. I have a recently He was an under 26. He was on my health insurance. He recently became over 26. He's on his own health insurance at a job. And he's constantly calling me, you know. And you can tell how exasperated or flummoxed he is because at 26, you don't usually start a phone call saying, "Mommy!" And that's what it always is. When I know it's a healthcare crisis. And he's always calling me about this crazy bill, or this happened, or why did he get one bill from this and one bill from that, and how does he find it? I have him trained. How does he find out if they're a network, and all these kinds of things. And he's always exasperated. He's always saying this, and I keep saying, that's the way it is. Yeah, I know that. This is what I do. Yeah, I know it's crazy. And then reading Libby's book, it sort of, the conversation, the phone call, actually, that one was about car mechanics, not healthcare. But it drove me back to this conversation I've been having with him for 6 months about how crazy it is. And I had been saying, well, yeah, I know that's the way it is. It's crazy. And in the middle of her book, it sort of jarred me. It's crazy. Right. Why am I not saying, yes, Zach, go out and change it? I think that what the book does, and if you haven't read it, I think it works on two levels. It works if our president has now informed us that healthcare is complicated. So if you want to understand a lot of those complications, it's a wonderful primer. It's a very easy to read description of this craziness that is our healthcare system. And if, like me, you know a lot of what's in the book, I still read it and there was this momentum of outrage that you would read, even things that are familiar to you, and you would read about the hospitals and the doctors and the drug companies, the devices, and it kept mounting, and to the point where you would read it the night before bed and not be able to sleep because you were sort of, that's the way it is.
That wasn't my intention. Okay.
Right, not that at my job I don't sleep anyway, don't worry about it. So, talk a little bit about how this outrage built up inside of you before you wrote this book.
Sure. And part of it was I started as an ER doctor in the 90s, and this is, I'd done a lot of freelance writing at the time, on the side at the time, and ironically, I left ER doctoring to work at the New York Times to cover something called the Clinton healthcare plan, because at that time, healthcare was still working pretty well for people like me who had good insurance, but it wasn't working for the people I saw in the emergency room. So I thought, okay, I'll go to the Times, I'll write about this for a few years, and then probably this will pass and I'll go back to being a doctor. And of course, it didn't, I didn't, and here we are, 20 years later, facing the same kinds of issues, but on steroids, to a point where I think we have a health system that doesn't work well for anyone anymore, right? And what was important in my kind of coming to this book and coming back to healthcare reporting was I'd spent 10 years overseas. And so I'd experienced a lot of other health systems. I broke a wrist in Stockholm and, saw the fanciest orthopedist in Stockholm who, had a little office and looked at my wrist, did an x-ray, casted it, and apologized insanely for charging me $400, So when I came back to the U.S. after 10 years away, I knew healthcare had gotten really, really expensive. And as Joanne was saying, what was the first article in your New York Times series, Pain Till It Hurts? And I said, oh, it was colonoscopy because I came back to the U.S. at 50. And I was outraged because I went to a hospital that was in network and I got the bill and it was literally $11,000. And I saw everyone look at your colonoscopy bills. You'll be surprised. And I'm a wonk, so I looked at this. And then, there was the happy note from my insurer saying that on my behalf, they'd argued it down to $9,000. And I knew this is really crazy if we're paying $9,000 for colonoscopies. Think of, we're going to be bankrupt pretty soon, right? And I knew in Europe you could get them for $300. So, so I went back to the Times, and when the Times, it was kind of the beginning of the ACA. I'd been with the Times the whole time, but not covering healthcare. Dean Beckhay, who's now the executive editor, said, will you cover the ACA? And I said, no, the only thing I want to do is write a series about why American healthcare costs so much. And I did, and thankfully he let me do that. So I did this Pain Till It Hurts series. And then, and with each article, my outrage built because I came back to New York at a time where social media was becoming really usable for journalists. And with each article, we put a comment space, and we got literally over 20,000 comments, and all the stories were worse than I knew, worse than my worse than my $11,000 colonoscopy. Or, we would do a story about getting stitches in an ear where I knew of bills from, $2,000 to $6,000, and someone would write in sending me a bill saying, hey, look at this one for $45,000. So my outrage was building and building and building, and I was on the projects team at the Times, and when they said, okay, this was a great project, and got a lot of readership, some awards, and time to move on to infrastructure, I was like, no. I have this bank of 20,000 stories. I understand, as often as, all of us journalists know, you write something thinking you understand, and then you realize there are layers beneath it that are even deeper because of all the responses you get. So I took all the stories, and many of them, I should say, were from physicians who were really distressed about the direction American medicine had taken, and said goodbye to the Times. I'm going to write a book. And I think the other thing for me was when you're doing a series, even a series that you're really, really proud of, you're picking off different pieces of the elephant that's American healthcare. And it became clear to me that they were all interrelated, that the hospitals were the hospitals kind of entrepreneurial profit-making mode was fueling the doctors, which was fueling the pharma, and it was this kind of endless inflationary cycle. So what I tried to do in the book is to use all those stories, and I think one thing I learned as a journalist is if you write about health policy, a lot of people yawn, but if you write about people's stories, they see how it relates to them, and this does relate to them. And my little soapbox is that one of the things I think we saw in the last election was that people didn't understand how all this stuff going on in Washington, and now don't understand, this high-risk pool stuff, the, per capita caps, how it affects them on the ground. And my point in using stories was to dig into our health system and make people understand that this is about their health, it's about their wallets, and I think we're seeing at town hall meetings now, people are kind of realizing that, but we've been slow to come there. So that's a long answer to your...
But I think that one of the things we've been seeing over the last few, the ACA was incredibly complicated, and the repeal debate is complicated, but I think it's been interesting because what has really emerged is the dominant political story, and it's what you hear if you're at a town hall or you can actually stream some of them and watch one. It is the pre-existing conditions, because you can understand. That's a fancy word for being sick, right? Or having a condition. Maybe you're not really sick, but you take medicine so you aren't sick. And probably everybody in this room has a pre-existing condition, even if it's a mild one, or somebody in your family does. So that has become sort of this pivotal, every patient that you interviewed now has a pre-existing condition. So whatever problem they had going into your book, if you had the sequel, it would be worse. Right. So one of the things you talk about is how it's an interesting book because the first half of the book is about this broken system. We can't call it a market, right? That's the first page of your book, quoting some economist who said, this is not a market. We don't have transparency. We don't have quality. When we do have pricing information, we can't match it to quality. We don't know. We're lay people. We're scared of a disease. So
when the ambulance takes you, you can't, in most cities, you can't even say, I choose to go to this hospital. You have almost no choice.
Well, one of my favorite factoids in your book was that ambulances, I memorized this one, until the 1960s, half of American ambulances were run by mortuaries. Right, that's another conversation.
By what?
Mortuaries.
Morticians. Right. But I don't know if it's better or worse now. Now they're mostly many of them are run by venture capital firms. So is that better
maybe
or worse?
It's the same thing.
And I think, one of the outrages to me, and things that I would, people from outside the country look at some of our bills and some of the stories I tell them and go like, why do you guys put up with this? This is ridiculous, So, the fact that fire department ambulances or fire departments put out fires for free, but if I get in a minor bike crash and someone calls an ambulance and I go, no, I'm not getting in. But if I get in, it could be will likely be a $2,000 charge that the fire department is charging me, with a mileage charge, with a charge for the oxygen that they stuck in my nose that I don't need, with maybe even a charge for like a professional fee for the 2 paramedics who may be volunteers, you know. It's just this crazy system. And plus the last chapter, of course, because if you're a joint venture or a venture capital business guy, you go, well, why should we be in network? We can make more money out of network. So they're out of network and I'm paying the bill. You know, it's kind of risen to a level of kind of absurdity, Kafkaesque, tragic comedy. So literally, like I wiped out, I think you saw me at this dinner last year where I had wiped out on jogging and had like a huge black eye and, you know, a broken bone. And, you know, when I wiped out in front of Columbia University where I lived at the time, you know, these students came running over and said, should we get an ambulance? And I was hurt pretty badly. And I was like, no, you know, no. And these 2 very nice students walked me to St. Luke's Hospital a few blocks away, but I think they thought I was insane.
But so. I mean, if you think the cost of an ambulance is bad, you should think about the poor rural people who have to take an air ambulance, which is a whole other can of worms. Before we're going to open up to questions, but I just want to have one observation, and I mentioned it to Libby before, and we didn't have time to really talk about it. We've been having a conversation about cost and coverage for a number of years. We passed the Affordable Care Act. We thought we had sort of begun to, not perfectly, but we had made huge progress in getting people covered. We had walked down the coverage path. We had done a little bit on cost. People disagree about how much, but we had done something on cost, and that was sort of a thought like, you know, it was stage 1 coverage, stage 2, we're going to go into cost. But right now we're in a different conversation where we're back talking about coverage, and we're talking about cost in a much more narrow way. We're talking about the cost of premiums. We're not talking about the cost of health care. And in order to bring down the cost of premiums, this political solution that's being discussed is have less in your plan, have fewer benefits, which means we're not talking about the whole bending the cost curve, which a lot of America didn't understand, but we're not even talking about the cost of care. We're talking about the cost of premiums, and we're talking about pay less, get less. So how do we connect that conversation back to the one that you're jumping up and down and screaming, you know, it's cost, you know, it's the cost?
Well, it is all connected in the end, and that's what I hope people will understand. I mean, part of the way we kind of got hoodwinked and kind of backed into this very, very expensive system is people were kind of looking at the wrong things. So we all were tuned, you know, because for many years we weren't paying premiums, our employer was paying it, there weren't deductibles or co-payments. Our insurance pretty much covered everything for those of us who were lucky enough to have it 10 years ago. So we got focused on, okay, what's the premium, what's the premium? And when we were just focused on that and insurance was just paying everything, you know, what does a business do? These are mostly for-profit businesses that are in our healthcare. They say, oh, the consumer doesn't feel this price, so we're just going to charge more. And, you know, that's where you see the prices going for, you know, if you, when my dad was a doctor, you couldn't charge more than, you know, $20 for a doctor's visit because people were paying out of pocket. So once you get into everyone has insurance and insurance doesn't, and so we're all kind of like, oh, insurance, how many of us have heard that, you know, don't worry about it, what it costs, your insurer will cover it. And in that kind of way, and in that kind of time, we mostly didn't. And guess what? You know, people who are more entrepreneurial said, as economics would predict, if they're not paying out of pocket, they don't feel it. So, you know, that $20 visit becomes $200 and maybe $2,000 in concierge care. And that happened in every part of the system with drugs. You know, we all said, oh, generic drugs are cheap. Well, there's nothing inherently cheap about generic drugs. And so entrepreneurial people in the generic drug field said, well, if they can do that with brand drugs, why don't we just raise the price and see what happens? And that's where you get, you know, Martin Shkreli's and the, you know, the $100 doxycycline pills. You know, it's really crazy. And now what happens, of course, is that, so we're all looking at premiums and outraged at premium prices. And the current political narrative is how do we bring down premiums? But of course, what we're all experiencing, and this is where the on the ground experience is so important, is yeah, my premium may be reasonable, but I now have a $5,000 deductible, or I have to pay, a $500 copayment for this medicine that I previously had a $20 copay for. So it's not just the premiums. And part of the second half of the book is like, okay, you have to shop. Where do you look? You don't just look at premiums. But I don't think people understand that. And I don't think our politicians, therefore, either understand it or want to understand it because they know the narrative is about how much premiums are going up. So you can solve that political narrative by saying, sure, we're going to, do these plans that will lower premiums. But guess what? When people actually try and use them, what they're going to find out is the way you lower premiums is by raising deductibles or narrowing what you pay for or excluding certain conditions. And that's not going to be very satisfying, I predict, to a lot of patients when they go out there and try to use this new cheaper healthcare, because it will look cheaper from the outside, but it will be because we're paying it. You're paying it. Every one of us is paying it. And I think, one of the false narratives that's been promoted in the medical world or the medical industry is that your insurers are on your side, right? They're in our corner. Like we don't think that way. And we know we don't like the insurance industry, and Mark Bertolini is paid way too much. But we think, I have coverage. They're going to fight for me. And it's like, you don't think that way about your car insurer. You don't think that way about your home insurer. I mean, basically, these companies are for profit, which is unlike most insurance 50 years ago. And their primary constituents are their shareholders. And they're pass-throughs. So, one insurance guy in the book says, they're not in your car. They're too big to care about you. Basically, they take in premiums and they pay out claims. And if claims go up and they can't rise premiums, what are they going to do? They're not going to suck up the profit. They're going to pass on those extra dollars to you. And we're seeing that in spades now. And I think so people are kind of going, well, why are my premiums going up? Why are my deductibles going up? Ultimately, that goes back to the prices we pay for all of those things. So if we're paying higher prices, even if your insurer is paying it, in the end, it just comes back to your wallet. And I think that's why we all have to be smarter. And that was part of why I felt like I really want to lay this out for people so they understand that even if you aren't paying it, we react to things that, where we open up the wallet and pull out the credit card. But even if you're not paying for that $120,000 hip replacement out of your pocket, we are paying it. When you walk into a hospital and say, oh, I love this place, there's free coffee in the lobby and all private rooms and good art, we are paying for that. It doesn't feel like it, but that's why your premiums are going up and your deductibles and your co-payments,
So let's take audience questions, because I can just go out and talk to her whenever I want. Right here in the red. Here's the mic.
Hi.
No, it's all right. The natural instinct, I want to read your book, and yet I don't. I think I'm going to be too cynical, too realistic. That said, not what are the 3 quickest fix, but what are the 3 most effective fixes, recognizing that we have a dysfunctional political system that can only adapt so much of what you're going to tell me.
Yeah. I mean, the second half is about, so what can we do, right? And as I'm a journalist, I want to stay a journalist, as is Joanne, so I can't say, this is the answer. I have my preferences, so what I try and do in the second half of the book is to lay out, here are a menu of options, because I think, a lot of people look at this system and they have that reaction, this is such a mess. I have 2 kids who are just starting to deal with it too. And they, put these bills in the corner and just hide, But I think, that's not going to work. That's not a good long-term solution because it will just get worse. So what I try and lay out is a menu of different solutions, which first for individuals, because I think part of this is that the more all of us just say, there's nothing I can do, it's hopeless, and write the check, it will just get worse, because that's how we've gotten here in the past. So, at an individual level, I think part of it is just asking those uncomfortable questions of your hospital, your doctor, and asserting your rights, your legal rights as a patient and as a person. Now that's, Joanne and I were talking, that's uncomfortable, right? To go into a hospital when you get that pile of consent forms and the one that says, I agree to pay everything that my insurer doesn't cover. I write in now, so long as it's in my insurance network, and if, that's not going to have a great effect if it's just me doing it, but it will because I'm a pain. I argue these bills. They're even in the book. And it's sad that it has come to this, but there are even kind of Mad Libs like letters that people can use to kind of protest your hospital bill. These are the principles I'm invoking in order to say I'm not paying this. And I think the more, and I hate the word patient/consumers, push back, the less we'll see of this. If this becomes a real the way we interact with our health system. One thing I would like to see, and it is not the answer, but it will help get us to an answer, is much more price transparency. You go to your doctor and you go to the hospital and say, what will it cost? And they go, oh, we don't know. And if you really push, they may say, as one person I interviewed found relating to a pregnancy, between $5,000 and $45,000. That's not okay. So, I think hospitals should show us their rack rates. They should have to publish their master price list. Now, in California, they're required to do that. In other states, they aren't. And hospitals resist it fiercely. And they'll say, well, nobody really pays that. And when you say, well, why do you ask those prices if nobody pays them? Well, first of all, it serves as the start of their negotiation. So you can get the happy bills that say, we saved you 60% when it was 60% on a crazy price. The second, which one hospital had actually told me, is because sometimes someone comes in with a suitcase full of cash and does pay. Well, that's not a good reason. When I go to a hotel, I know what the rack rate is. So again, not the final answer, but moving us in the right direction. In Australia, when you go into the hospital for an elective surgery, you get a binding estimate of what your cost is going to be, what the procedure will cost, and what your share will be. In France, there are prices on doctors and doctors' offices. Now, I'm not saying that's a great solution, but it's a start, because even if we're not paying it, the place where I got my $11,000 colonoscopy wouldn't charge that if they had to put that on a price list in the lobby. It's embarrassing. They know it's not worth it. So transparency is one thing where I think we can start. I think some way to control pharmaceutical prices is really, really, really important. We've heard this from both parties. Every time there's a Martin Shkreli or EpiPen moment, there's like
I call it my conflict of interest pen, because
Right.
I carry it, and I'm
Right.
beasting. I always say I have a conflict of interest pen now with me at all times, right?
Exactly, and so I would like, people have talked about allowing Medicare to negotiate drug prices. Every other country has some way to negotiate drug prices en masse. We don't. There's bipartisan bills that, come up each year. It's usually Klobuchar and McCain about allowing for, and now Bernie Sanders is in on it too, allowing for controlled drug imports from Canada. That would do it too.
But that's also been around for something like 15,
Yeah.
20 years.
Yeah, and I think, maybe we won't see that pass, but I think the more people get fed up and the more they express their outrage, the more likely, because we don't pressure, we at Kaiser Health News were looking during the presidential debates last year for some discussion of healthcare, on the ground healthcare issues. There really wasn't any. It's only at these meetings afterwards. So I want people to become healthcare voters, know what your congressman thinks about what are they actually going to do about controlling drug prices. Do they support Medicare? And what you find is often, there's a lot of, well, we've got to do something about this. And guess what? Who's their biggest constituent if they're from, for example, New Jersey? It's pharma, right? There's a lot of lobbying that prevents some of these things from happening. So I want everyone to be a healthcare voter. Know who your insurance commissioner is in your state, because that person can make these directories that are so inaccurate now accurate next month if he or she wants to. Most of those insurance commissioners now are from the insurance industry. And many of them are elected officials. They should be elected from consumer advocates. California is lucky; they have a very activist insurance commissioner, and as a result, even though he doesn't have a lot of power, he's had a very effective bully pulpit to make things better. So
Now to run for higher office from too.
Yeah,
You had a
he has
question here?
ambitions there.
Wait for the mic. Wait for the mic.
Thank you. My question has to do with the profit-making aspect of the hospitals and the insurance companies. And sadly, I don't know how much Aetna and United Healthcare and Hospital X, what their profit is. But would that be relevant politically?
Well, yeah. Yes.
I mean, I'm sorry to.
No. It's we've heard of some of the big insurers simultaneously pulling out of exchanges, saying they can't make money, and then the next day announcing record profits from other parts of their business. So. I'm just throwing out ideas. I'm not endorsing them, but could you say, for example, you want to operate in our state? Well, then you got to operate in both the government and the private commercial insured. You could do that, but these are for-profit companies, so they're doing what they're supposed to do. Hospitals are a different issue, and one that I think deserves a lot more attention. I mean, most of the hospitals in the United States are not-for-profit. They don't pay taxes or pay minimal taxes in exchange for doing what's called charity care and community benefit. One of the things that the ACA did that I thought was, as a policy person was really important, was to say to all these hospitals, okay, show us what you're doing to deserve that big tax break. So the hospitals, and if you really want to be wonky, you can go get your local hospital's Form 990 and look at Schedule H, and you'll see what they claim they're doing to deserve, the tax breaks. Now, I think that's not gotten enough scrutiny because we've never said, well, how much do we expect to get from a hospital in exchange for that tax break? You can look at what they say. The charity care is a little easier to look at. The community benefit is like pages and pages of little writing. But for many hospitals, you will find it not very satisfying. It's things like, we let a farmer's market take place in an empty parking lot on Saturday. That, to me, is not community benefit. So I think one of the things as voters we should ask our local politicians is to look hard at what these hospitals are giving us in exchange for their tax breaks. And if it's not enough, maybe it's more valuable to get the taxes than this kind of notional community benefit. There's a mayor in New Jersey who just won that suit successfully. It's often extremely difficult, but the judge, who is not a healthcare person, looked at what the hospital said it was doing, and he said, this isn't a charity. This is like a big profit-making company. The other thing you'll find is because hospitals, by definition, as nonprofits, are not allowed to make a profit. So you can look at their operating surplus, which is often large and invested in things like building new wings and buying art. And again, we have to, as Americans, think, what's valuable to us in a hospital? Is it all private rooms? Is it? And I don't want to dismiss that. I mean, I like having a private room when I'm in the hospital. But if you look at hospitals in Europe where healthcare costs are much cheaper, they look like high schools. They are not fancy places. And I think we have to decide, are we willing to pay for hospitals that look like hotels or not? And that isn't to say that there aren't some hospitals who have what we call a bad payer mix, who treat a lot of Medicaid patients, a lot of poor and uninsured, aren't doing magnificent jobs against great odds and really struggling. But, someone said to me, well, Apple Computers gives away a lot of computers, but that doesn't make them a charity. So I think, we have to do a better job of sorting out what is a nonprofit hospital, where it's truly nonprofit, and where we feel like it's deserving its tax break.
Yeah, I think a lot of people tend to think that a nonprofit is mission-driven and a for-profit is for-profit, when
Right.
in fact it's really just their tax status and their board and some of their governance structures. It's not necessarily a good or bad. It's how they are set up.
And that includes, as you know,
There's some very
as
wealthy
in the book.
nonprofit hospitals.
Yeah, and that includes a number of the some of the most powerful hospital chains today are some of the Catholic hospital chains who, continue to invoke in their advertising this the sense of mission when, meanwhile they have venture capital partnerships and, it's. You probably have a lot
It's
more to say about
complicated.
this than I do. Yeah.
Question right over here. This gentleman, wait for the mic, I think, for the.
I wanted to ask you a question about private practitioners. We didn't talk about that.
Yeah.
Sometimes easier to talk about hospitals.
Yeah.
Private practitioners today are getting squeezed
Yep.
by the insurance companies. So they have several choices as they get squeezed. They have to make a living.
Yep.
Some of them go out and get rid of involvement in networks. They don't take insurance. Other of them have boutique practices.
Right.
Others who stay, what they can do is try to see more people in less and less time, which is terrible.
Yeah.
So I wanted to know what your recommendation is for the state of private medical care practice, which involves all of us.
Yeah.
But
No.
many of them are also now staff, that
Yeah.
they don't want to be solo practitioners or small group. Many of them are actually staff or affiliated in one way or another with working for a big healthcare system.
Yeah. And I think this is the irony when we allow finance and markets to govern how healthcare is delivered totally, is that the thing, the thing that patients and doctors that always made that relationship powerful was the interaction and the time together and getting to know someone. And most of our economic incentives that are driving healthcare and healthcare reform kind of move us in a very different direction. They move in the logic of, efficiency, revenue generation, So often the person who's hurt the most by this, who I hear from, is the solo practitioner who's just trying to see the patients he or she has seen for years, trying to spend the time, doesn't want to order the tests, wants to figure out, because what's the most efficient way to do it? It's to order a bunch of tests before you've seen the patient, get the results back, and then say, oh, take this pill. It's the most efficient form of medicine, and the most profitable is not what most people say they want. And I think that's a real challenge. I hear from longtime private practitioners who say that Medicare is now their best payer, paying $50 a visit, which is not very good, because they're not in good bargaining. Today, medicine and how it's structured all depends on bargaining. What's your bargaining power? And individual doctors compared to insurers or hospital systems or device manufacturers or drug makers have no bargaining power. And, I think they've found different, really imperfect solutions to that. some have gone to the boutique practices where they'll say to patients, okay, you're in my practice. Some are just pure concierge, but I hear more and more from patients who go to the doctor they've seen for a long time and now have discovered there's a membership fee, like a $500 or $1,000 membership fee. And that makes people understandably uncomfortable. What does it mean? And the answer from the business manager is often, we'll return your calls, promptly, or, you'll get, and first of all, you wonder, well, if I don't pay the membership fee, can I still be in the practice? Or am I going to get second-class care? And part of my, now I sound like an old fogey doctor, is like, I'll go, yeah, returning calls and seeing patients in the hospital. Well, that's what doctors do. That's the definition of being a good primary care doctor. But we don't have a business model for that, right? So if Medicare is only, or if the private insurers are only paying you $50, what can you do? So the other solution people have come up with is, they join groups, or even more problematic in many ways is they'll allow the hospital to buy their practice, right? Again, sounds like a good idea, and I think so much of it in healthcare, it's like, it sounds like a good idea, because then the hospital comes in and it's very tempting, right? Don't worry, we'll do your billing, we'll take care of the finances, we'll deal with insurance.
You just get to see patients.
You just get to do what you do. And I get it. As a physician, I would probably jump at that at a first pass. But then what a number of physicians find is it's kind of a weird Faustian bargain, because your patients who you're very committed to, suddenly your office is branded as hospital, and the hospital in its billing is charging a facility fee. And your patients who, maybe you like the radiologist down the street who you knew did a really good job for a reasonable price. Well, that's not okay, because your hospital is part of, the St. Joe's hospital system. So you have to send your patient there for the x-rays and the blood work, which is, literally instead of $7, $700 for the vitamin D test. So I've heard a lot of physicians who tried that and then ended up pulling out because they said, my patients were being ripped off, and I didn't like that. The good caring physician who thinks of him or herself not as just a steward of your health, but also of your well-being in a general way. So I think, I am seeing an interesting model where private practice doctors form into groups and try and negotiate collectively, and that I think we should support that and encourage that. The problem is many of the players, because of consolidation in our system, are so huge compared to what even a group of 100 doctors could do, that that doesn't always work out so well. That being said, we do have to figure out a way to we've said this over and over again, reimburse quality, reimburse the things we say we want in medicine. We have to reimburse face time rather than procedure time, which we over reimburse now. We can shift those reimbursement values. But again, you look at how reimbursement values are set in this country. They're set at something, you were going to get really wonky. The relative value RUC, the Relative Value Update Commission. That's where doctors from a bunch of different specialties.
But it's dominated by high
right,
paid.
there's a fun chapter on this in the book where one doctor from the dermatologist called it 15 sharks in a tank with nothing to eat but each other. So, every specialty society tries to get the most money, and the primary care docs are kind of the little fish that's being eaten by everyone else. It's a very flawed rate setting and value setting system.
And
right
somewhat
now.
secretive as well.
And very secretive,
right.
yeah.
You have a question right here? And then we'll go over to this side.
One of the outcomes I thought we had achieved with Obamacare was the perception that health was a right. And I guess I'd like both of you to comment, since you each have expertise. Do you think we're in danger of losing that?
Joanne?
Without I mean, I can just tell you that I don't think this country reached that conclusion. I think that one of the I'm not talking about my own personal perceptions of this, but covering it, I don't think everybody in this country does believe it's a right. And I think that the whole fight over health care, that's one part of it. I think that the reason we can't stop fighting about health care is it's become such a powerful proxy for how do we feel about government.
Yeah.
Is it a right that the government does have to protect and enforce, or is it not a right? And is it not a government role, or is it a federal government role or a state government role? So I think that people who support Obamacare or the Affordable Care Act would tend to agree with you. Probably I have not talked to all of them. And I think many of the people who oppose it do not think it's, maybe they may think it's some kind of a right, but not necessarily a right that the government should be enforcing. I don't think everybody, I know I've watched focus groups and I've read polling data. Not everybody does think it's a right. So they think it's a right for very small children.
Yeah.
But,
And
right.
I think though, the ACA and its struggles did move the needle slightly in that direction, if not openly acknowledging it. The fact that these 20 million people who got insurance and are now poised perhaps to lose it, that's a real constituency that has come to think of healthcare as their right, at least, and many of them are in red states.
But so much of the conversation we're having right now is really about the exchanges. And this bill that went through the House has extraordinary changes to Medicaid.
Yeah.
And I mean, I've written about it, my staff has written about it, but it is not getting the same national attention. Pre-existing conditions is something that it is easy for us to identify with. It's not complicated. There's no payment stream. You either have one or you don't, and we're all vulnerable. I mean, trying to explain, entitlement spending and per capita caps and there's also a lot of public misperception about who's on Medicaid.
Right.
I mean, I think a lot of people think that if you're really poor, you get taken care of. That's not the case, or it wasn't the case. So, that's sort of not what she's written about, but go home and read go online and read about what's in Medicaid, because that's also very pertinent to is healthcare right? Who is being taken care of? How are they being taken care of? And those are people who don't have the money to pay the kind of bills that, 20,000 people, emailed Libby. Right? I think you have your hand up for a very long time over there. Yeah. Wait for the mic.
Acknowledging that within our current political climate,
I don't think people hear you. Right? Is it on?
acknowledging that within the current political climate, our health system can only change so much. The players aren't going to change, and that type of thing. But also acknowledging that we're not really addressing the cost discussion. Do you think we can successfully see a shift away from pure fee for service, rewarding quality outcomes, whether through value-based care and what we're seeing in Medicare? Do you think that's a successful way to address costs in the broader healthcare system?
Well, I think, particularly with what we're seeing in Washington, I think nationally, we're moving away from thinking about that. But I think one major constituency that has, to me, been really asleep at the wheel in this is the employers, who I think should be taking this on much more forcefully. I mean, when people say, well, why haven't I gotten a raise in the last 10 years? It's because your employer has been paying more and more and more for healthcare costs. And employers mostly, and, I get, just like Joanne's son, I get why employers look at these choices. There's a story in the book about a university. They used to have one benefits person who would just decide on health insurance 20 years ago. Now there are layers of consultants who say you can choose choice A or choice B, and it's also complicated. They just choose like two of the cheaper ones and say, wow, I'm glad we don't have to deal with that again. But, some of the large employers have huge market power, and they have huge market power locally where they can have an impact. So they're interesting ideas. One that I'm fascinated by, something called reference pricing. It's worked pretty amazingly where it's been used in California. Some big employers will say, okay, we're going to look at the state where we cover lives and where we have employees and say, what does it cost to get a reasonably priced hip replacement? and they'll come up with a number. Not independent health economists will figure this out, say $35,000, and they'll say, okay, that's what we're going to pay to the insurer who mediates their health purchasing. And if you want to go to a place that costs more, you pay the difference. But if you want it covered by your insurance, you have to find a place that will do it for that. And guess what happens when a big employer says that? Not only do the employees shop for something that's covered, but all of these hospitals that were charging $100,000 go, oh, okay, we'll do it for that. They lower their prices. So there are a lot of effective levers that big employers and unions can pull if they feel motivated. And I think how to get them feeling motivated is a big question. I went to a presentation last week in New York from the Sustainable Business Council on Health, who were behind putting out a movie about pharma pricing and the ripoff of pharma pricing. I think they're starting to get more energized. So I think this focus on how can we bundle care in that way, say we're going to pay $30,000 for this kind of care, and you doctors, pharma, device makers, hospitals, you duke it out about how you split up that money, but this is what we're going to pay. Medicare did that. The center in the last administration, there were a bunch of demonstration projects that worked pretty well. Our new HHS secretary does not like those.
Isn't it, right?
So I think he's put them on hold for the moment. But they've worked pretty.
The ones that are underway, he
Yeah.
didn't stop. They're cardiac. There's a cancer. There's a cardiac. There are a few that he's put on hold. There won't be anything else mandatory. He won't do any more mandatory ones. He didn't rip up all the ones that are already out there.
But it's certainly an interesting and doable idea. And hey, if you take it to the extreme, you get to the HMO model, right, where everything is covered for a set fee for the year. I know we always say that Americans don't like that; they want choice. The part of the problem for me is certainly where I'm from in New York. HMOs got a really bad name in the 90s where they mostly did not deliver very good care. And so there's a real lack of trust in that model in this country for the most part.
Right. And there's a part of the Affordable Care Act that we're not arguing about. Believe it or not, there is a part. There's a lot in there about the Center for Medicare and Medicaid Innovation. There's a lot of experimentation. It's all very acronymy, patient-centered medical homes, accountable care organization. It's not so easy to know what quality is, and it also, as consumers, you could have price, say you have price transparency. You don't necessarily know, do I go to the cheapest one, or do I want the cheapest MRI in the block, or do I want the most expensive MRI, or do I want, Goldilocks? If you don't have the quality information too, it's really hard if you're going to come away with Libby's book and say, I'm going to go out and be an informed, engaged consumer, and I'm going to negotiate and find out. It's really hard to even get the information. In addition to being, it's hard to do, but it's also hard to get information and connect it.
This is why, though, I think, when I speak to medical groups, employers need to step up to the plate. Physicians and young, I speak to medical students, I think, they did not go into this to deal with prices and costs, and they mostly don't want to and don't like it, and I get that. But your doctor knows which radiology centers around his office or her office do a good job. So I think, unfortunately, I do say to my physician, okay, if I need an x-ray, do you know which place around here will do it for a reasonable price? If I call these radiology centers, they'll probably say, we can't tell you. But if my physician calls around, or he has his office manager call around, they probably will tell him or her. And I want him or her to say to the one that's charging $1,000 for a wrist x-ray, I'm not going to refer my patients to you because I don't want them getting ripped off, But that's a big ask for people who are already overburdened with a lot of tasks that are very uncentral to medicine.
Back here, the green tie.
Hi, I'm Mac Odell. My son was paralyzed with Guillain-Barré for several years. At age 11, my wife had breast cancer. By some miracle, we had a pediatrician when we were in Massachusetts who said, I'm closing my practice because I'm going to join a new thing called Harvard Community Health Plan. We followed him.
Yeah.
If we hadn't, we would have been in a catastrophic situation because his illness cost well over $1 million. My wife's cancer cost plenty too. I don't know, but it's somewhere along the line, Ted Kennedy was holding hearings in Washington, and we went to testify that every American should have the option of something like this. Every American should do it. It's nonprofit, HMO. It was working fine. I now am part of a nonprofit HMO, you might know it, called Kaiser Permanente. It's the most popular health plan in the Mid-Atlantic region. You've been talking this whole time about the private insurance industry. That's not where the problem should be. We just got to get rid of that. It's just terrible. I mean, why do we tinker with this rotten private system when there are really good alternatives that could be supported? The best, most popular of which is Medicare.
Yeah.
It's by far the most popular health insurance scheme in the country. It's a single payer system. It works. The Kaiser system works.
Yeah.
Cleveland Clinic works. Mayo works. Why are we tinkering with this busted system and even spending time talking about it?
Well, that's a good question. That's a really important question, and I will say when people say, "Oh, single payer, it's too radical," I do point out single payer Medicare is a single payer system. It's pretty, not that it doesn't have problems, but it is pretty popular, and it's the most popular. Right, and one thing that Hillary Clinton proposed at the very end, probably spurred on, I would guess, by Bernie Sanders, was lowering the Medicare age. And, you could get from here to you could say we're going to lower the Medicare age, by X years, every few years. And guess what? In, a couple of decades, we would all wake up and go, oh my gosh, we have a single payer system. How did this happen? So that's certainly, yes, the HMO model, Medicare, these are all things that work where they're applied. And the question is, will the U.S. apply them? And, I think the answer of why it's so hard to get there is that, in other countries too. In Germany, there are a lot of sickness funds. The insurers, they're all by definition, they have to be not-for-profit. Now, as we've seen, not-for-profit in this country in healthcare can mean very lucrative, but not for profit. So, why don't we take that profit motive out? That's a political question. And I think the question for all of us going forward, and one of my reporters did a really nice story about this in the New York Times Sunday Review a few weeks ago, is that healthcare has become the job creator for America since the recession. And so any attempt to unravel it or go to a more cost-effective structure will involve, there's a chapter in the book about Pittsburgh. Go to Pittsburgh, go to Cleveland, where the steel mills have shut down. Healthcare has been the source and the fuel of the economy. So I think we do need to get this, nearly 20% of our economy is crazy. I've spoken to too many people in the book who are paying 20 to 30% of their household income for insurance and minor healthcare costs. People who move out of the U.S. because they have type 1 diabetes and cannot afford it even with good insurance. So it's a huge problem. We have to my goal is not, I would love it if we could get to, French levels of spending or Canadian levels of spending tomorrow, but I think my goal right now is to start turning this ship around to move towards lower costs. And I think we have to do that carefully so we don't end up with a terrible economic problem and jobs problem.
It's already 18% of our economy. I
Yeah.
mean, we're spending 18% of the economy on healthcare. Way back there, it's $3 trillion is what our
When you
healthcare
talk
system is.
about healthcare being the job provider, that's clearly the case, and it's going to be growing even more. And what, even though we're spending so much on healthcare, what about the minimum wage payers, the CNAs, the GNAs, all of that level, and structuring their jobs and making their jobs and having enough of them on? How do we effectively make that happen?
Yeah, I think one of the sad things about our system is that many of the people at the bottom of the healthcare workforce pyramid don't even get health insurance with their jobs. You know, that's and what I worry about now is I saw that the Beth Israel Deaconess in Boston, I just heard from someone when I was up there that they're cutting 1,500 jobs. So I think a lot of hospitals see this cost containment on the horizon. My big worry is that they're going to cut, you know, look at the jobs in our healthcare world. I don't want them cutting nurses or cutting patient care people, and I worry that's what's going to get cut. A lot of these jobs are administrative jobs. They're, you know, hospitals have coders, insurers have coders, doctors have to go to coding courses, they're coding consultants. You know, that's the layer of healthcare that I really question. Where's the value for healthcare? I mean, I get that it's part of the business structure, but I really hope as we unravel this mess that goes away and people say, well, what could they do? You know, we have a lot of people, homebound elderly, who could use home visits. Meals on Wheels is terribly underfunded and not able to feed as many. You know, we could redirect some of that workforce to areas that are really patient-centered. You know, one of my kind of aha moments in writing the book was, you know, we've all talked about patient-centered, evidence-based care and how that's the goal of health reform, patient-centered, evidence-based care. And at some point I stepped back and I was like, wait, you know, what other kind of healthcare is there? And you know, the answer is it's healthcare as a business now. And that's the part that, you know, the question is how to move away from that. And obviously single payer gets away from a lot of that kind of administrative stuff, but I am not, you know, it's not my decision to say whether Americans will accept single payer or not. That is one thing that has worked in other countries. So has socialized medicine, so has a more market-based system with some kind of rate setting or rate corridors even. So I'll leave that up to, you know, the voters to decide, but.
Back there?
Thank you very much. My name is Asia Lightfridge. I actually practice emergency medicine here in DC at GW, and I'm also the director of our health policy fellowship there for emergency docs. So my question has to do with the difference in what I perceive in philosophy, left versus right wing, as far as costs. The American Health Care Act that passed the House on yesterday is, in my mind, tax reform in some ways, in terms of tax cuts, as well as cutting billions of dollars from the public health system. CDC, ARC, HRSA, it's estimated we'll lose about $18 billion, I believe. And then cutting on the front end also, you know, spending, and so taking insurance away so that spending is going down. And then I think on the left side, it's more, okay, well, if we insure individuals ahead of time and keep them healthy and keep them out of the hospital and out of the emergency department, and that overall that will result in savings, and also that it will contribute to our economy in terms of jobs. And as you talked about, there's already a workforce shortage in terms of healthcare providers. And so my question is, any thoughts around how to try to bring those two sides together? To, you know, whether it be based on logic, which is helpful, in the way of evidence, as far as what does work better, as far as cost savings on the front end, or more on the back end? And just any thoughts on that? Because I'm more and more I'm seeing that's kind of the big conundrum right now. I think it's just like, where do you cut costs, before or after?
Well, Joanne, I think the incentives are, look, to me, the classic example of this in a way is, what does the health system respond, a system that's driven by finance and profit is much happier to treat a kid with asthma in the emergency room every month than to go back to his or her home and remediate for mold or, it's the incentives. We get exactly what the incentives encourage. I mean, this is what economists looking at our system will kind of say, of course this is what happens because this is what you're rewarding. I think the question of how to get the right and the left together and how they see this, I don't see them agreeing on much of anything. I mean, my one hope when
They can't agree on what color the sky is right now. It's really,
it's pretty bad. I mean, I had my small hope is that, when the new administration came in, it was, well, Americans aren't getting a good deal, which we're not. But I don't see any actual movement to, if you want to look at this as a business proposition, we're getting a really bad deal for all the money we're spending.
on the wellness and delivery system reform, I think that is an area that is actually less partisan than you might think. I think that the idea of how you spend it and there's all these technical problems of how do you score it, because prevention savings are over many years and we look at budget windows in 5 years. But I think in terms of, is there an appreciation among some on the right as well as some on the left about the need to do more, like community-based care instead of hospital care? Are there people on the right who understand value-based care or moving away from fee-for-service to more quality-based? I mean, I don't think that is an entirely partisan conversation. I don't think it's entirely not. I don't think everybody is in agreement or understands it, or that they agree on all the details. It's sort of a 30,000 foot. But there was another bill passed last year which has a whole another set of acronyms called MACRA, which is really a bill to change how Medicare pays physicians and providers. It was bipartisan. It took 17 years to find something they could agree on. But there are tools now to try to move, and it's not easy. I mean, even if you had complete political agreement, technically it's not easy to change from fee-for-service to an episodic or bundling or whatever kind of continuum you want. But there is some shift happening. There are incentives happening, and that is not being repealed. Does everybody, is 100% agreement on how fast you go or how flexible you are? I think sort of the overarching concept, there are people on both sides of the aisle who understand that, and there are people who on both sides of the aisle who don't have a clue of what you'd be talking about.
And I think there's,
the coverage and the spending and the role of government, they're really divided. On some of the other issues you raised, I think there is some common ground.
Now, the problem is, like the what's it called, the physician payment, the Commission on Physician Payment Reform was a bipartisan commission. Senator Bill Frist was on it, and they, very strongly recommended to get away from fee-for-service medicine. But, there are
a lot of interests who
and I would say
profit from the current system.
Yeah, there are a lot of, and I think one thing that works against the kind of thing you're talking about, which is distressing to me, and is very much centered in this current debate of patients as consumers, is each year you better, go shop around for better insurance. Go look for better insurance. And the only way these preventive things make sense is if you're in Medicare for a long time, or you're in the same HMO for years. In that case, those institutions have a great interest in doing things up front to keep you healthy. But if we're all shopping around every year, there's not that incentive there anymore.
Right, there's things like something that is going to pay off in 25 years or 10 years, the insurer that my employer, I get insurance through Politico, right? I mean, right now we have Blue Cross, but Blue Cross doesn't know if I'm going to be on Blue Cross 15 years from now, right? So the need to spend now, and this is not unique to healthcare. Look at our infrastructure. Look at anything.
Right.
The need to spend now for payoffs later. Politicians have trouble with that. Yeah. Here. Hi. We've got maybe two or three more questions, so make them quick, both of you. Okay.
Reporters have a knack for focusing on symptoms of problems that help people become outraged. But I don't hear an underlying structural analysis that recognizes the huge public investment in healthcare. I mean, 2/3 of total healthcare expenditures are public dollars. And that isn't the impression that most people have when we think of our private insurers and our private doctors and our private hospitals. And focusing on the private helps us think, what's in it for me, not what does our system need for me over time. What do you think we can do to help people understand better that they have a long-term interest in improving the health of the total population, which ultimately they're paying for through these public taxes and expenditures? And is that how these other countries developed a political commitment to an infrastructure that reinforces public health?
Yeah, I think, this is going to sound terrible, but my editor at the New York Times, when I would do articles about international environment, would say, yeah, but what does it mean to people on the Upper West Side? So I think, people are, and that he is a great journalist, but I think people are very self-interested, right? And they don't think, especially in our country, this is part of American individualism, there's a much more of a culture of thinking about the whole in some of the European countries. So I think, to me, the way in is through individual outrage, and I think we're seeing it. But I think, we have to understand, and this is part of, very much a theme in the book, is that a lot of these drugs, which individual companies are making a lot of money off of, that's from federally funded research. They are saying how much it costs them. It's costing all of us. Likewise, when we can't negotiate drug prices, who is that hurting? It hurts Medicare. It hurts, I get calls, and I'm sure Joanne does too, from people at the CDC who are like, these vaccine prices have gotten crazy, and we're spending so much for vaccines now, and we can't really get a good price. And so it affects all of us because, first of all, either our taxes go up, or there are a whole lot of things that the CDC can't do for public health because their money is all going to pay for the basic childhood vaccines now. So I think there is both the individual, people start thinking this way through the lens of individuals, I think. I always like to point out to people when they talk about the Canadian health system, one of the fun facts of the book is the most popular person, there was a poll of Canadians about who was the most popular Canadian in history, and I thought it was going to be, like Wayne Gretzky or Justin Bieber. It's the guy who started the Canadian National Health Service, right? So I think, that should tell us something. I think there's a lot of, we're all kind of dug in, and we have the best healthcare system in the world, and it's expensive because we get things first. I think we're all seeing, and I hope we're all seeing, which is kind of what my work has been about, that our results are not so great compared to the rest of the world. I think one of the most damning stats I've seen was a recent study showing that people with cystic fibrosis, a very serious long-term chronic disease, that when I was a medical student, kids died of usually before the age of 20. Now they're living much, much longer with a lot of high-tech treatments, but the lifespan of people with CF is longer in Canada than it is in the US, significantly longer. So all this stuff that we're in theory doing better and getting first may for some people be magical, but on the whole, it's not. And I think even for those really well-off, well-insured people, we're getting the most expensive treatment, but not necessarily the best anymore. And I hope we're all waking up to that.
We have one more question. It has to be quick. So not a speech, please, just a quickie. And a quick answer.
I'm a gastroenterologist, and I wanted to get back to your colonoscopy.
Go for it.
Because you're the most
you wanna know.
sophisticated health seeker that probably exists in the world. And you probably knew that getting a colonoscopy at a hospital is 5 times more expensive than in an ambulatory care center. So my question is, A, why'd you get it there?
Right.
And B,
It's 10 years ago.
but this is a more generic question. This is really important. There needs to be independent internet sites for people to go to understand where they can get quality and where they can get the best price for their bucks. No one should have a colonoscopy in a hospital if they're willing to save the system money.
Right. And why did I do it? Because I'd been out of the U.S. for 10 years, and I was ignorant, right? And my concern, I think, as many healthcare consumers, was what I asked the New York Times office was, how can I get this at no cost? I wasn't saying, like, what's it going to cost the system? And I didn't realize, I mean, the full weird story is I trained partially at this hospital, which was Sloan Kettering, and because they had a cancer screening clinic, and it said, you know, it's in our network. I signed up. And I had thought, like their breast cancer screening clinic, which is off-site and does mammograms for $100, and I've always gone there, that it would be a similar kind of thing. And when I checked in, you know, I went to the room I was supposed to, and it was weird because I was getting like a hospital admitting band and, you know, booties, and I was being wheeled into an operating room, you know, and I was extremely alarmed at that point and knew, you know. But then I got my propofol, and it was like, you know, I forgot about it for a while. But now I'm, you know, and that was why the first article in the series, that Pain Till It Hurts series, was about colonoscopy. Right. And one of the things it looked at was, you know, so when your doctor says, oh, you can have the colonoscopy on, or the office says, you know, Tuesday or Thursday, and Thursday he or she is in the hospital, and Tuesday he's in a surgery center, that will double the price. And most people just go, oh yeah, Tuesday I'm off Thursday, so I'll do it there, not understanding. And no one divulges that that's going to double the price. And no one also divulges that, hey, at the hospital, the anesthesiologist is going to be out of your network. And
right. And you can't find out. It's really hard to find out.
Yeah.
There's no place for the consumer to go, some independent, nonprofit place.
Well, there are more and more of these kind of consumer-y health sites that will say, like, you know, Fair Health.
There are a whole lot in the back of the book. She's got a whole bunch of sites.
And Clear Health Costs, Prater USA. They're all there, and they give patients some information. They're all, I would say, useful but flawed in one way or another. And Joanne and I were talking about this because, you know, maybe one person, as we know, you know, maybe one person got a good price at a place, and a week later it will be different depending on the insurer. Or maybe, you know, there's Fair Health uses a metric called usual and customary. Well, if all the gastroenterologists in an area are charging a lot, then usual and customary is high. And hey, I'm not going to go to like St. Louis for my colonoscopy, so it's not so useful. My thing, which I would love to see, is this not to have to be a kind of investigation. Like, I don't have to investigate how much bread costs at West Side Market. I can just go in and so that's why I think transparency is such an important first step. And we're seeing some clinics put up prices, but they tend to be the more niche clinics that serve a paying out of pocket population rather than an insured population, because the insured population, again, tends to be pretty price
Oh.
insensitive until they realize that, oh, this isn't covered by my deductible, and then they become after the.
We are out of time.
Yeah.
I would have.
We are out of time.
We are going
and,
to.
Sorry, everyone.
No, that's quite, clearly, we could have gone on and on and on and on, but I promise you, no
And
later
into
than
tomorrow,
1:30.
right?
Yeah.
There you go. If you haven't bought it, if you haven't read it, you now have lots of reasons to do so.
Thank you.
So thank
Yeah.
you both for being here. We appreciate it, and we'll see you all next time.
Thanks.